Hi, I'm Dr. Matt Tabbut, Director of Ultrasound at MetroHealth Medical Center. Today we're going to learn a lot of fun things about bedside ultrasound, but really for any of this to make sense, we need to have a foundational understanding of why ultrasound works and how the machine functions. So for the next 15 minutes, we're going to talk a little bit about physics and the knobology of ultrasound. So let's dive on in. Now I know what you might be thinking. This is the boring stuff. I want to get into the echo and the lungs and the abdomen and all the cool stuff. There's no way I'm going to get any of this. But the reality is, physics is a little bit fun. And the key for understanding ultrasound physics is just to keep it simple. We can go into great depth, but there are really some basic things that you need to know as we go into ultrasound physics. So medical ultrasound is the graphical display of reflected sound waves, right? And the way the body interacts with these sound waves really affects the image that's visualized on the screen. So sound exists along a spectrum, and medical ultrasound exists right in the middle of that, in the 1 to 10 megahertz range, and exhibits all the same properties of sound in any other portion of the spectrum. And so as we know, sound is a wave, right? There's periods of compression of those air molecules, and there's periods of decompression of those air molecules. And the speed of sound, which is relatively constant in certain tissues, is equal to the frequency of the sound wave times the wavelength of that wave, right? And so the speed of sound is something that's relatively fixed. We can't affect the speed of sound in a certain tissue, but what we can do is we can change the frequency with which we interrogate certain tissues. So we can use a low frequency or high frequency, and the frequency we choose will have a definitive effect on the image that we see. So high frequencies are generally used for things where we want crisp resolution. We sacrifice our ability to penetrate into the body, but we get ability to resolve the tissue a little bit better and see details. Whereas low frequencies, we get the penetration, but we lose the resolution. So remember when you're sitting at a stoplight and you hear the car behind you, you just hear the thump, thump, thump of the subwoofers, but you don't hear any of the song that's actually being played.
Because you know I'm all about that, baby.
This is the same principle at play, where you can hear the low frequencies because they penetrate, but you don't really hear any of those high frequencies because they don't really penetrate outside the vehicle and into your vehicle. And so low frequency equals better penetration, high frequency equals better resolution. And in this example, we can see the heart where it's kind of grainy and the resolution is not very good, but we can see deep into the body. Whereas on the right-hand side of the screen, we can see the Achilles tendon with really high resolution, but we really sacrifice that penetration because we're using a high frequency transducer. So the probe, when you're scanning, emits this sound at a certain frequency, the frequency that you select, and it emits it in a pulsed fashion. So it sends the pulse and it listens back for the reflection of that sound wave. And when it receives back that sound wave, it displays it based on the time that it took to get back, as well as the intensity of that returning sound wave. So the things that return back sooner are displayed higher on the screen, and things that are more intense are displayed in a brighter shade of gray. So as we apply this to the patient that we're scanning, what's close to the skin surface will appear towards the top, and what's farther away from the skin surface will appear towards the bottom. And the brightness that's on the screen is a reflection of the intensity of that reflected sound wave that's picked up by the transducer. So when we think about reflected sound, we need to think about two things that affect the way the sound is reflected, and that is the type of reflection and the speed of sound, or it's kind of its cousin, the acoustic impedance, right? The nature of the interface has a bearing on the appearance of the structure that we see. So there's two types of reflections. There's the specular reflection and the diffuse reflection. Specular reflections, think a mirror, reflect sound waves in a very robust way in a very singular direction, and the result is kind of a bright line. So think about the pleura or the diaphragm or different fascial planes. Those are specular reflectors. Whereas diffuse reflectors reflect sound in different directions. Think of the liver, the kidney, or the spleen, these different tissues that we're going to interrogate. And the components of these tissues then scatter the reflected sound waves. So what returns back to the probe and what's displayed on the screen is kind of this echo texture that has some mid-gray appearance and is very textured in its appearance. Secondly, the degree to which the tissues resist sound, or the impedance, or by proxy, the speed of the sound through those tissues has an effect on the image that's displayed as well. Most tissues in the body allow for sound to travel somewhere in the neighborhood of about 1540 meters per second. But there's two main outliers, and that's air, you can see on the top of this diagram, and bone, you can see at the bottom of the table here. And these reflect and transmit sound very, very differently. And so when there's a large difference between either the velocity of the sound in tissue or the impedance, the resistance of that tissue to the movement of sound, you're going to have a larger reflection. So where that that difference is small, you're going to have less of a reflection. Where that difference is great, you're going to have a larger reflection. And so what we're going to see with air and what we're going to see with bone is a very bright surface with not much reflection behind it. So we're going to see some shadowing behind that. And so if we look at this image, we can see all these different types of things come to play. So you see the liver, the kind of the main thing in the middle, kind of this speckled gray appearance. It's the diffuse reflector. Above the liver, or just to the left of the liver, is this bright line. That's going to be the diaphragm. So that's our specular reflector. And right in the middle, we see their gallbladder, right? And we have this bright line at the posterior portion of the gallbladder, which is the stones inside the gallbladder. So that reflects a profound degree of acoustic impedance difference between the fluid in the gallbladder and the stones. And so it's going to reflect a lot of that sound energy and have a deep dark shadow posterior. And then even on the sides, we see some air that has the bright line with a very grayed out or dirty looking shadow. So here's the air, here's the stones, the diaphragm, and then obviously the liver right in the middle. Now, science is the art of what's reproducible. And in order to understand the world, we sometimes have to make some assumptions about the way things work or standardize the way things work. But the world doesn't always act according to our assumptions. And when these assumptions are violated, they create artifacts in the ultrasound world. And there's two main artifacts that we want to talk about today. So the first artifact we want to talk about is shadowing artifact. And this occurs when the sound encounters a very strong reflector and is either partially or completely reflected back. And this happens with air or bone. And so in this picture, we see an example of bone, here a rib, that's causing a deep dark shadow that's posterior to that rib. Similarly, air does the same thing, but it gives us kind of this dirty looking shadow. So underneath the liver margin here, we have the loops of bowel, right? And so air is going to appear as this hyperechoic line, which kind of this grayed out staticky shadow that just really doesn't have a shape, but it kind of covers everything up and that's underneath it. The second artifact we want to talk about is called Reverberation Artifact. And this happens when sound is trapped between the transducer and a highly reflective surface or between two highly reflective surfaces. And so the air reverberates between those surfaces and occasionally gets out and is picked up by the transducer. And so what you'll have is multiple linear lines at regular intervals relative to what's being reflected. And so in this situation, it's a needle. We can see the needle and the reverberations posterior to that needle. And here we see the pleural line, right? So you can see the pleural line right here, and then the reverberations distal to that are equidistant from the pleural line to the probe surface. And here's another example of a reverberation that looks a little bit different. This is a B line in the lung ultrasound. It's reverberation with inside the alveolar space, creating this comet tail artifact right here. Next, let's talk a little bit about Doppler. So Doppler is the graphical color or spectral display resulting from the frequency changes caused by movement of fluid or tissues. So by convention, anything that's going toward the probe is displayed in red, and anything that's going away from the probe is displayed in blue, and the velocity is reflected in the intensity or the brightness of the color that is displayed. So now that you've formed the image, let's take this to the bedside and talk a little bit about how we actually use this, right? It's important that we have a standardized way to create these images so that those who come behind us and see these images can understand them and we can reproduce these images. So each ultrasound transducer has an indicator on one side, and that corresponds to a dot that's on the side of the ultrasound image that's being displayed. And by convention, anything that's done in the sagittal orientation, we orient that dot towards the patient's head, or anything that's done in the transverse orientation, we're going to orient that dot towards the patient's right. So this image of a patient with a AAA is performed in the sagittal orientation. So everything towards the top of the screen is going to be superficial. Everything towards the bottom of the screen is going to be deep. And that which is displayed towards the left, towards that probe indicator marker, is going to be towards the patient's head. And that which is displayed on the right is going to be towards the patient's foot. And if we twist that to the transverse orientation, we keep the superficial deep orientation, but now what's on the left of the screen towards that probe indicator is going to be on the patient's right-hand side. And what's going to be on the right-hand side of the screen here for us is going to be the patient's left-hand side. So let's transition and talk a little bit about the machines themselves and the knobology and how we make these things function. We're going to start as we scan our patients by selecting the correct probe. We have 3 probes to choose from. We have the linear array, which is going to be a higher frequency transducer. We have the curvilinear array, which is in the middle here, which is going to be kind of a low to mid frequency transducer, and the phased array, which is going to be a low to mid frequency transducer as well. And so for things that we want resolution and not much depth, the linear array is going to be great. For things where we want general abdominal scanning or general general scanning where we need some penetration, the curvilinear transducer is going to be our choice. And then when we do cardiac imaging, where we need to get in and out of rib spaces but still need that penetration, we're going to select the phased array transducer. When we talk about the machine itself, there's 3 basic functions that we need to know. Those are 2D or B mode, M mode, and Doppler mode. Right? So B mode is going to be the general scanning mode. If we hit the middle button, most machines are going to say B or 2D or something to that effect. That's going to take us to B mode or 2D mode or just grayscale mode. It's going to allow us to get the image that we need to see of the patient's anatomy. M mode shows movement over time. So when you activate M mode, the machine's going to place a line somewhere in the image. You can move that line back and forth, but what it's going to do when it's activated is it's going to display whatever happens underneath that line stretched out over time. And so it's a really great method to be able to demonstrate movement, particularly the heart or the lungs or things like that, where we need to show in a still image that this thing's moving. And so if you look on this machine, just to the left of the center button is the M mode button, which you press to activate this. Doppler, as we talked about, is another mode that shows movement. Here's movement of mostly liquids, but you can show movement of tissues, and it's going to show it in the color fashion. So on the right of that 2D button is going to be the Doppler button. Now, in addition to those basic modes, there are several functions that the machine can do that will allow us to be able to manipulate and better view that image. The first one is the image preset, and this is really important. Every machine comes in with some factory-built presets, and then we've added certain presets that fit our needs. So when you start your exam, you want to make sure you're in the correct preset, and this is going to optimize all the other settings, probe, and all the other functions to really get the best image easily as possible. Once we've selected the proper preset, we can change some of the functions that allow us to manipulate this image to get the best image possible. The first one kind of goes without saying, it's the depth. There will generally be some form of a slider or buttons or a knob that allows you to adjust the depth of the image. And so as we can see, as we adjust that depth, we can see the structures of interest getting larger or getting smaller. And so you really want to optimize this to put the structure that you're interested in somewhere towards the middle of the screen. The next function we want to talk about is the focal point. Just like a camera, the ultrasound machine has the ability to focus the beam at certain areas within the image. So as you can see on the right-hand side, there's a little double arrow indicator that goes up and down that will set the focal point in this image. And you really want to set this to be in line with the area of interest in your image. Next, we want to talk about the gain. The gain is like the volume knob on your stereo. It doesn't affect the quality of the music that comes in, but it affects how loudly you hear the music that comes out. And so the gain can be turned up or turned down to increase or decrease the brightness of the overall image. And there's usually some form of a button, slider, or knob that allows you to adjust the image. So you want to turn this to be somewhere in the mid-gray range where things aren't blown out, you don't lose your highlights, but you also don't lose items in the shadows. And finally, there's frequency. As we talked about, the frequency that you select can really affect the ability to penetrate or resolve different structures. And so there's a button that allows you to change the frequency, toggling between penetration mode, a general mode, or a resolution mode. And as we can see in this image, as we toggle through that, we can really improve either the quality of the near field image or the quality of the far field image. Now, there are many more functions that your machines can do, and over the course of today and throughout the rest of your training, you're going to learn a lot of these functions. But this is a basic primer that will get you started so that you can start enjoying doing bedside ultrasound.